So with that, I want you to remember the whales and dolphins, that we need to leave no one behind in governance, but foremost, a reform agenda is needed for the PPP in health. Thank you.
Thank you, moderator. Basically, I know most of us, we are very aware with this topic because it's a short time past where we have a very deep dive discussion regarding this matter. So, as the question says that we as a country, how can we overcome the challenge with a fragmented system in the country with regard to public and private sector? Government through Ministry of Health has done some different initiative to make sure that we work out with this problem. And basically, before maybe let me start way back before these are kind of moving quickly of digitalization in the health sector. There was several digital systems which are deployed in the silos. I mean, deployed as pilots, like we say, pilotis. A statistic which when we are doing an assessment on our first digital health strategy. So you may see we were like 100 plus systems, and that's not only for the government. Those total number of systems consist of public and private, because you know when they say this system belong to health sector, sometimes when they are doing this assessment, even if the system has been deployed to maybe Kairuki, maybe TMJ, Seife, all private facilities, they say that this system belongs to the Ministry of Health. But for sure, for us, we as the ministry, we do accept, because we know that those are systems which are regarding to patient level data. And basically, if you take a look on instruments of the health, a minister responsible for the patient, a minister responsible for the health care delivery in the country is a minister for health. So that's why you may find all these kind of discussion has been pushed to the Ministry of Health. So now we as a country now, where are we now? I mean, to make sure that we are overcoming this kind of problem. Ministry of Health, with collaboration with PORAG, collaboration with the e-government authority, and Ministry of Science and Technology, we have started doing some stuff to make sure that we are reducing number of digital systems in the health sector. And one of the initiatives is an assessment which has been done by a government agency on July 2021. It's one of the assessments which has gone through by looking on available digital system in the health facilities throughout the country to make sure that to take a look on the compliance of the deployed digital system, because at policy level, we have provided like a guidance or a document which provide like a minimal standard and specification of the digital system that's supposed to be deployed in the facility. So through those kind of documentation and framework, eager workouts with different facilities in collaboration with the ministry team. So the assessment has been done together with Ministry and PORAG and eager. And the report basically were submitted to the permanent secretary. And basically, we at the Ministry and PORAG together, we started to work out with those challenges which has been addressed by eager to make sure that we are complying with the standard and framework that we are provided as the health sector. So we started work out with to see how best this system maybe could make data exchange smoothly. So we deploy a layer. We have an interoperability layer called Health Information Mediator. That is for the ministry side, but also for the PURAG side, they deploy an advanced interoperable layer, which is called gateway. These two interoperable layers are talking to each other. So system deployed on a PURAG that maybe want to exchange data with the system which are available at the ministry side, they are exchanging data through these two layers. So we may find like we have something which already starting, and I'll much talk on the side of him, Health Information Mediator, where right now we have connected like 39 digital systems, starting from the level of facility to the national level. And this 39 system has made making an exchange of like 240 use cases. What do I mean when I say use cases? I mean use cases is the number of transaction exchange from each system to those 39 systems. So you may find we start doing something regarding to data exchange, and basically one of the critical area that has been addressed also by our deputy minister is area with working with this insurance scheme, our insurance scheme, National Health Insurance Scheme, NHIF. Yeah, we as a ministry, in collaboration with NHIF, also we have already started doing something to make sure that there is a smooth validating patient data from one level to another level. For now, NHIF has looked a central portal where when the patient moves from one facility to another, the next facility may take a look how many maybe medications or diagnosis done by the expert, maybe doctors or clinician from one facility to another by entering name or number. Basically, we are much looking to see how best we can integrate with the national identification number to make sure that when the patient move from one facility to another facility, so when you get into that identification number, could pull the information of the patient, what he has been attended from the previous facility. So ministry through NHIF, also we have already started doing that, and that is one of the initiatives to make sure that we are taking care of this kind of fragmented system. But also, as the fragmentation itself, the world fragmentation itself, you may find it's like having too many systems, and some they are doing like the same job. It's a silos. So what we do, we make sure that we meet with different meetings and to take a look by doing an assessment on system that we have. And if we find like this system and this system, they are doing like the same work, we do merge together and then we come up with one system. For example, I can say from the level of facility, we had like, it was like 16 EMR were deployed. That's belong to the ministry and PURAG, like 16 EMR. But that's even is due to a number of facilities we have, we as a country. Sometimes we are there at the ministry, or my colleague here at his office there at PURAG, you find like a certain IP has been going straight to the facility, deploy a digital system, regardless whether ministry knows or PURAG knows. So that's where now it creates more problems. So what we do is like we stopped it through IGA. We say that no facility is allowed to change or to adopt new system because we want to work out where they're available and see how best we can reduce this, and then we can see in the future how best maybe we can adopt a better sustainable solution to make sure that we have few but workable. Time up? Thank you very much. Basically, in summary, that's how we move on. We Minister of Health, government agents, and PURAG. Thank you very much.
Thank you very much. Uh, should I say shalom for the Hebrew guys? Peace be with you guys. My name is Mark. Um, Currently, we've been, as PRH, we've been working with the PHC, the primary healthcare, and we have been implementing the digital solution, which is GoTromis, to the whole of the PHC, which of course is the system which is being allowed by the government to be implemented to the primary healthcare facilities. We have been up to 1,563 health facilities right now. That includes district hospitals, health centers, and dispensaries. But also, that's for the standalone versions on the facility. But right now, we have 25 health facilities which are centralized. Of course, thanks to UNICEF for 10 facilities there. Thanks for GZ for the facilities in Tanga. But also thanks for the Global Fund with the ongoing efforts. I think we'll be going up to 33 facilities next month. And thanks to COICA, who are to implement 290 facilities in Dodoma. So both facilities will be centralized. So with the experience that we have, to begin with, the health workers, I think one of the lessons that we have learned out there is the user training and support. Of course, you could implement the solution today and people start using it, but when you go back after a month for the monitoring, you find that people who use the system, they're not using it. Even Honorable it's not like people, the system is not in place, but rather people are redundant in using it. So I think we still need people to support these users so that they could be having more frequently education, capacity building regarding the digital solution that we've been taking out there to them. But also another lesson that we have learned, of course, it's also based on the user experience. See the problem with the interoperability. Right now, most of our systems, the EMR, of course, we have to admit, most of the system, what we are doing, we're just doing some integrations. Systems, because integration and the interoperability are two different things, because the integration is where, of course, we could have two people speaking Swahili and the other one speaking French, but you will need one person to translate those languages so that you could understand each other, right? That's integration. But if you're speaking about interoperability, it's having a standard, like you are two people, then you speaking French and I'm speaking Swahili, then you find one single language that you agreed each other to use. For example, right now we are using English. Of course, I'm a Swahili guy, but we have people who can't hear Swahili. They are English speakers. So we decided that we should use English so that we could understand each other. So that's interoperability. That's where comes the likes of HL7. That's where comes the likes of FHIR. And right now, WHO insists in using of FHIR, of course, with the smart guidelines and the stuff. How people, to localize the guidelines so that it could meet the specific needs of the native country. So with the interoperability, you see that there, we lack the seamless exchange of informations. You see, so for me, coming from one facility to go to another facility, you find that if the system are not talking to each other, then that means there are some medical records, medical records that are missing to a certain patient. That's where there was some of the blames from our honorable that people have been costed twice as much. So I think the interoperability is also a problem, even though the integration have been done. Of course, for example, GoToMis has been integrated with the DHIS2. See, the GPG have been integrated by NIDA. The MSD could save some out of stock commodities to GoToMis. So there's a lot of systems that we have been integrated, but not being interoperable. So there's a need to change these systems to be fire compliant, so that we could make the interoperability easy. Okay, another thing is the workflow of integration. Of course, the system that we've been implementing, we should make sure that at least it follows the workflow that currently we're being used. Even though we know the digital solutions are there to streamline the business process. Another thing is the data security and the privacy. For the data security and the privacy, of course, for us, what I've seen is that we should make sure, because we know it's a healthy data, then we should make sure we encrypt everything that concerned with the patient, the client, and implement the role-based access control. Another thing is there is this resistance to change. We need to make sure that we implement the change management, but also the resource allocation. We should make sure at least the government, all partners, get some budgets for these facilities to. Another thing is the feedback mechanism. You have a client and he goes to the facility, but he doesn't get. You don't get the feedback that the service that he has been receiving, was it okay? For example, in GoToMis right now, with the Mama na Mwana, we have the thing. We're doing it with the UNICEF. But also, there's one thing. Yeah, of course, another thing is the right for the patient to, the accessibility of the patient. I always think about, at least a client should have control, manage some of his clinical information, that we should implement the patient portal, so that, to do the appointments and the stuff. So I think there are some stuff that through the lesson that I've learned out there when implementing our digital solution, meaning GoToMis, I think this is the one which is key. Thank you very much.
Thank you. Hi, everyone. Yeah, sure. It's such an honor to be part of this forum. I have experience implementing digital health interventions at the community level. Loud? Oh, sorry. Is that better? Okay. I was saying it's such an honor to be part of this forum. I have experience implementing digital health interventions at the community level. So this is something that is close to home. And before diving into answering the question, I would like to share a bit about the principles of implementing digital health technologies in such a way that they are actually easily adopted and they help to transform the healthcare system. Digital health technologies have potential to transform healthcare systems and improve health outcomes when they are designed and developed by adhering to principles of sustainability, making sure that they are safe, they're affordable, they're accessible, and centering around the patients for whom we're designing these solutions for. They need to be localized, which means that they need to adhere to the national priorities and policies and operate within the available resources. And successful implementation and institutionalization of digital health requires an integrated approach. And I think this is something that we have been hearing a lot from other speakers, that it does require looking holistically at all of the different key spheres that are very crucial. So that includes leadership, finance, policies, and at the very center, the people, which are the patients as they're navigating through different healthcare journeys, but the health workforce as well, that's at the very forefront in enabling and driving the healthcare system. So when all of these steps are followed and we are adopting appropriate digital health solutions, we then get to generate a wealth of information, which is the high quality data that can then be used to optimize how we are organizing and coordinating the health resources. And this then helps to address some of these challenges that we have already been hearing from other speakers. It can help address the issues of increasing access to affordable care. So there was an example that was given that if facilities are implementing healthcare systems that are adhering to the standards of information exchange, when a person visits one health facility and moves to another health facility, their data moves with them. And then they get to save up on costs that they could have taken on additional tests. But also the health facilities get to save up on resources as well. If the community health workers in the community are using simple decision support tools. The data that they collect can help identify some of the patients with risks and enable them to be able to provide personalized care that meet the unique needs of the individuals. Another area where presence of data can help improve and strengthen the healthcare system is in increasing transparency and accountability. So there was an example given around management of supply chain. When we have robust systems, we are able to provide the healthcare providers, the health management teams, and the policymakers with the data that they need to see the visibility, so the flow of the commodities, the consumption, and all of this helps facilitating in the effective management of the overall health resources. And the last point, the information that we are generating, the knowledge gained, can then help to inform the policies, the decision-making processes at all levels within the healthcare system. But this is an ideal scenario, and we know that the reality on the ground is very different. We were able to hear some of the challenges, and I think it's just as important to continue talking about the challenges and making sure of finding ways of how we can collaborate together in addressing some of these challenges. And I would like to end with a question, something that I've been thinking about more recently, that I think would benefit from a diversity of opinion and thoughts. And the question is, how do we ensure we are developing timely, inclusive policies that are responsive for emerging technologies in healthcare, like AI, to make sure they benefit everyone while also addressing the potential risks? Thank you.
Your response has been quite acceptable. Thank you again also for taking time. And last but not least, the question to Harishbha.
Chair, I have started coming from the private sector, and the government has been advocating PPP, public to private partnership. So the question is how can the private sector contribute to investments and financing of digital transformation and innovation to ensure wider scale and sustainability of the digital agenda? Over to you.
Thank you. Thank you so much for that question. Let me start with the theme of this session, which says it's international cooperation. To me, one of the things that private sector from across the world brings on the table is the extensive knowledge that is already existing in the rest of the world. Health information systems are not new. They have been around for many years. And therefore, there is something to be said about learning from others. Yes, Tanzania is different. Yes, it has got its own challenges. But there is a lot of the core of health systems that has been developed and is available across the world. What does that mean? What it means is that interoperability is not something that started yesterday. This has been around for decades. These systems come with the interoperability standards built in. They come in with the data security, the GDPR, the HIPAA compliance requirements built in. They come in with all the different kinds of coding of diagnosis built in. They come in with the kind of workflows that are popular in most hospitals. So the biggest benefit you have is you get access to 3 or 4 decades of work that has been done by other people across the world. Now we can ignore it, that's a choice you always have, but my suggestion is we don't. Then the question comes is, okay, but then I have vendor lock-in. Once I buy from you, I can't go anywhere. The answer is no. You get source code. You make changes that you want, which is part of technology transfer, which is part of capacity building, which is part of localization. For example, the solution that we talk about in a few minutes, it can be used from the largest consultant hospital with hundreds of beds to a dispensary. And you can use it on computers, on laptops, on tablets, and on phones. And they will work across the board. You can have one central data center where you implement the system and all the hospitals share one single data center. Today, Tanzania has got fiber connectivity to most places. Internet connectivity is good. Trust me, we connect a lot of organizations. So that is there in place. Let me give you an example. Our partner, Laborate Yuan, is here. He came with me. In only 2 provinces of Spain, they manage 6 million medical records. For 6 million citizens, that can be accessed by any doctor at any time that patient goes anywhere. In Latin America, millions more. My personal belief is that there is a tremendous wealth in using these capabilities, these skills, this knowledge, and then building on it to suit the local needs, to customize it, to do whatever technology transfer that is necessary, instead of reinventing the wheel. But that's my thinking. The second point I would like to make is public-private partnership. Already our partner Laborate runs a number of hospitals in Europe, in Spain, as well as in Latin America on the PPP model, where they implement the systems. There's an infrastructure partner, and then there is a payment based on the service or the number of patients or the number of users or whatever works. And in that way, you don't incur a massive capital cost when you can roll out the solutions and the systems directly. So this is what the private sector can actually bring in. Another example, in our case and in Laborate's case, 10% of our profits go into research and development. So these systems are not static. They're not waiting for somebody to change. What you earn, you put it back into the research, into the development, so that these are living systems. They constantly evolve, they constantly develop, they constantly progress. In my opinion, the amazing systems, investment in infrastructure, for example, we can provide the source code, we can do technology transfer and localization, we can do capacity development, and we can actually bring in the infrastructure that is necessary to make the dream come true. Thank you.
Thank you, Harish. Back from Tech. I think the clapping also signifies palatability with the response. Having said that, let me recap just in brief so that I can remind you of what was presented by the 5 panelists as you are writing up your questions, because I would advise you to have your question very straight and not beat around the bush. We heard from Josephine the role of international organizations, and she emphasized on the need for governance, and this governance need to prioritize on investment. So she's actually looking forward to see the various international parties, including World Bank, etc., investing or supporting the country, coming up with equipments that will help the country forge its way forward. That's where she sees the international collaboration or cooperation coming in. She winded up with emphasis on the need to leave no one behind, and she mentioned the various groups that or should be targeted. My small question would be, she didn't mention the poor among those who did not invest behind. Perhaps she may want to tell us. And the other mind-boggling question would be the title, which was mentioned by other panelists, that experience tells us that the fragmentation, partly, if we leave aside the governance side, is contributed by our collaborators, supporting different systems in different places. She didn't address this. Perhaps while she's winding, she may want to. Mr. Yomo addressed the issue of fragmentation and talent, which actually was a major challenge that was put forward by the Honorable Minister. And the country positively related. And if anything, we were challenged to have responses or plausible answers to the question, so that at the end of this workshop, we should send those responses to him. So just to say the least, he told us what is being done, and what is planned to be done. However, the very question that the Honorable Minister put still need to be answered. Progress. Until when do you think all these will work? We have been given the numbers: 39 systems, 240 cases, 16 EMR. We know this country has, the last time I looked, it was 8,000 to 9,000 facilities. And we are talking about less than 1,000. When the Honorable Minister gave us a deadline of January. Are we seeing ourselves covering even a quarter of this in January? That I think Mr. Yomo may want to respond to. Coming to Mr. Matanda, he gave us an elaborate response on lessons learned from the district health systems, structures, and services. Again, we had a very good, elaborate presentation on what is being done. And the question remains that I asked Mr. Ilomo, progress is when we have been seeing integration, sort of interoperability being an agenda since way back in 2012. Today, it's all I think. Now, people want answers. The policymakers want answers tomorrow. How are we going, what are we going to tell them? What are we going to assure them that come January, this over 10-year stalemate will be solved or resolved? That requires a deep, well-thought answer. To Emma, thank you for a very nice response to the question. That was followed by a topic which shows that many of the audience understood you. I have a small question to you, because most of your response was the ideas which, if you can give us a live example of what a farm access or your project has done in which community and which system blocks you include finance, human resource, or whatever, so that we can hear and people will go out with the message that there is something working. And lastly, to Harry, again, thank you for your elaborate response, which again was for, meaning that people really understood you. Why? Because you were down to earth, that here we are, we don't need to invent the rule. These things have been there for decades, and we are still palpating here and there, trying to find our own local made solution. Okay, local made solutions are good, but if they are going to take us another 4 decades, are they invented? That's a big question that we as participants need to ask ourselves. But question to the question to Harry would be, you mentioned a number of countries that have utilized the existing system, and they have well. Just like the question to them, a country in Africa, you know, sometimes out tomatoes. A country in Africa that has done it and will keep that, so that we can go out with an example that Ghana has done. But if I go today and tell the minister that Venezuela has done, of course people are rich, they have if we could get that, surely that would help. And if you could go further with your experience of Tanzania, tell us, why do you think our policymakers and digital health experts don't like the ready-made solution? Surely you must have an experience. Having said that, I think now you are quite well reminded of what our panelists I'm told we have 10 minutes, so I will take 3 questions at a time. And then
Yeah, we will respond.
Okay, 2 questions from here, 2 questions from there. And being gender sensitive, one will come from there and one from there. And then yes, and up will be the priority. So it will be 4 questions. 2 here, 2 there. Who is the first? Come on. Madam. Aya, yes. I have one there. For a woman, this. So then we go that side. Yeah. Questions, comments? Yeah. Thank you. So, gentlemen,
Thank you very much, Mr. Moderator. My name is Verie Sambu. I work National AIDS Control Programs, Ministry of Health. My general question for all, we understanding and we discussed here during these conservations based on the issue of the integration and the interoperability. So we understanding current as a country, we have private hospital, special private hospital, and majority of a private hospital using a licensed systems. So it's not easy for us as a country to integrate with a private hospital. What strategy between our ICT team together with a PORAG to make sure this system are integrated and communicated together in order to strengthening and making sure all data are corrected at real times. Also, not only that, we understanding we have a military hospital, so it's not easy to access the informations and the reactions based on the military side. So what is strategy behind the MOH to make sure all the systems are connected together, and it's easier for us, especially for the issue of the quantification and planning purpose as a minute. Over.
So my question was about whales and dolphins. When you're explaining that they're big players and then they're small local players and they all need to be communicating with each other, what came to mind was that a lot of time the information is somehow lost in translation, or maybe there's not enough of a push from one side, or maybe the dolphins are slow. So what kind of people to be able to bridge that gap of communication, and what can maybe like international corporations do for Tanzanian maybe students or maybe the young population in order to educate them and empower them to be able to bridge that gap. Yeah, thank you.
Thank you very much. Now the floor is yours. We can go again with the same order. Starting with Joseph. We have 2 minutes for each, and if you exceed, I will let you.
Yes. I will. Thank you, moderator. I will keep the time. So the first question was about poverty, those living in vulnerabilities. And what I meant with the 3 groups, mental illness, disabilities, and girls and women, was to actually look at the segments of the poor portion of the population. If we apply a multidimensional aspect on poverty, poverty is not only in materialistic terms, but it's also about lack of power and voice. And if you cannot be an active citizen, You cannot co-create digital solutions. You cannot use digital applications. So when digital solutions are rolled out, we have to include these vulnerabilities within the poor segment of the population to make sure that digital solutions are also applicable for people living with disabilities, mental, intellectual, and physical, but also those with mental illness. The second question on a fragmented system, if we work as civil society with private complementary solution, how come we are not managing to integrate better? I think this is a very valid question. What we need today is to walk together. We are lacking comprehensive health data, we are lacking comprehensive health planning, and we are lacking integration in the system. So one of the very purposes of us becoming a sponsor and a stakeholder in this Health Innovation Week is to actually bring actors together, private, public, civil society, business, with the government and academia, to start integrating digital solutions together. Finally, my last second on the whales and dolphins. I believe information is key. Research and training is key. We must be able to integrate these actors, and the students we have from secondary school are here for the very reason of symbolizing the importance of raising capacity with the next generation.
Thank you, Mr. Moderator. Basically, I will start with the first question that you have been asking regarding to timeline or time frame for issues with the interoperability. First, maybe we all expertise in the area of ICT, and I'm sure that all of you know that issues with integration, interoperability has got no end. But maybe for specific case now, which has been addressed by our deputy minister, we as experts, we did a plan, maybe reaching June next year, for the case of facilities, communication from one facility to another. I mean, taking care of continuity of patient from one facility to another through our national insurance scheme will be done. So, but that is according to the plan that we have with a team of experts at the ministry. But the door is open, as the deputy minister said. If we can come in, can chip in, and can maybe advise how best we can minimize this time frame, because we did plan this according to resource available by looking financial resource, human resource, so and time resource, to make sure that we have the plan which is compliance to the availability of these resources. The next is the issues with the question from Mr. Sambu regarding to the private hospitals on how they will be able to make sure they are submitting the data to the central ministry. Basically, is what we are doing right now, from the paper-based facility electronic medical records, they could be able to submit their data to the big system, aggregated data system at the central ministry. We have a big system which monitoring patients. We call the summary data system like DHIS2. We have like a system which work out with medication, which is called ELMIS. So maybe I'm sure what focus of Mr. Sambu is how these facilities could be able to submit their data in this system. Basically, this question has got two parts, because first we should look on a data side people. I mean, what are the terms and conditions to make sure that data sharing is possible, but also we should make sure that we are looking at the technical side. How can we tailor best to make sure that data can be flow from private facilities to the central ministry. So we have basically, and we started like from the perspective of policy level, we started developing I can say like a framework which will allow these private facilities to share their data to the central ministry by indicating maybe standard, what the standard should be with the system, what we'll share also API for available system to make this work easy for them to make sure that they could be able to share their data to the central ministry. So, I mean, this process has been started and the ministry is working together with my colleague here from PORAG. But also the second question from Mr. Sambu is regarding to military facilities data. This is an area where also we as a ministry have been focusing a big challenge because Mr. Sambu is aware, because at some point we ever meet in one meeting where we have been discussing regarding to facilities that belong to military. Basically for them, they don't want to share their data to the central ministry. What they say is, we as a ministry should develop a mechanism for them. They are going to give us their data, but not us to fetch from what they are collecting. And I know because maybe that is due to some privacy with the data that they have. So we have already starting like a discussion on how we can customize a DHIS2 software, and will be used at a military level. They will be installing their data, and they will allow the data that they want to allow us to. That could be shared to us, and not all the and not grabbing all the data from them. So that we have already our frameworks to make sure that we are able to share data from facility for which you are operated under military. Thank you.
Yes, of course. Looks like the blame here is for the IT guys. But we forget that the people have got a great role on this, because the ICT has got only 10% from the 100%. People have got 70%. So when we try to speak about this, if you want to integrate, let's integrate people first. Partners should integrate yourself so that you could come out with the one word, right? Regarding the interoperability that has been mentioned earlier, of course, speaking about the PHC, right now with the central GOTOMIS, you could do referrals from the any facility that is using central GOTOMIS, or we have the GOTOMIS. We have got using the central GOTOMIS, and the facility you don't have a sonographer. So you could provide an access to a sonographer at the facility B that could only read for you, and then you send back the result, and then you could continue with it. So it does that. So that's why I'm saying we need to get some proper information from proper people. Otherwise, we'll not achieve whatever we wanna achieve. Another thing about the integration, of course, from the private hospitals to the government and the government hospitals. Of course, I think there's one initiative which was once initiated by Minister of Health. There were the thing called the NCR, the National Client Registry. It played. The logic was for it to play a role as a healthy information exchange. So with that, and right now we are, we have that project that we are going on with the number moja, right? So we could even use after the completion of the number moja, that project, that every citizen should have his own unique number. Then it would be easy for us as digital health experts to capitalize the number moja, so that within the health information exchange, that could exchange data even with the facilities which are not public facilities. Thank you.
Yeah, thank you. So my question was around what I had shared was an ideal picture, and I was asked to provide an example of a possible implementation of those sort of like ideal scenario. So I'll be sharing about a project that I worked on earlier this year, where I was looking to explore ways to optimize and tailor the health services that have been provided by CHWs in a maternal and child health program that's implemented in Zanzibar. The CHWs in this program are equipped with decision support tools that they are using to provide healthcare services, and they include things like screening the women, the pregnant women for danger signs, providing them with counseling. And what I did was analyze the data from this program to create a predictive model that would be able to flag the women that are at high risk of delivering at home, so that the CHWs could then focus their efforts and tailor them to addressing these particular high-risk women. And this does address the challenge of health resource. So we know that there are few CHWs and they have to serve such a huge population, but having much more sort of like targeted and tailored systems to direct them to which clients are like they have the most needs, it does help them to streamline their work and just making sure that they're providing that personalized care. Yeah, thank you.
Thank you. So I have two questions. Where has this been implemented in Africa? The proof of concept has been completed in Uganda, and it will now continue with the implementation after a series of tests were being done. I'm happy that you mentioned Venezuela. I do know they have a lot of oil, but trust me, there are some countries, Uruguay, Mexico, and Honduras, which all use the systems, and trust me, they don't have oil, or they have very limited oil. So, and they can still use these systems quite effectively. The work environment, I understand that maybe Europe is very different, and I appreciate that. But the Latin American environment is very similar to the kind of environment we have here. The second question was, why do policymakers in Tanzania not favor or maybe are reluctant to consider ready-made solutions?
Mashombo, usikubali Mashombo, utaibiwa haraka sana.
Okay. All right. I thought somebody was threatening me or something. No, okay. So some of the issues that we have seen are things like they don't want to buy a license, and then they do not want to have vendor lock-in. In other words, you can't go to any other vendor because it has changed. What has changed is that in this particular case, you actually get the source code, which means you can modify, you can change, you can maintain, you can build, you can do the technology transfer. It is designed using conventional open tools. So these are not proprietary tools. In other words, these are conventional tools out there, and people can actually make use of them. You don't want to pay annual maintenance, that's quite fine. You can continue maintaining on your own. The only advantage of annual maintenance is that you get updates and upgrades because the system is a living system. It's constantly improved, it's constantly developed. So I believe that we have a very effective answer to a lot of the policymakers' questions. One last one, sometimes some people tell me, but you know, ready-made systems are expensive. Really, who has worked on the cost of own development? Can we really do a little bit of apple-to-apple comparison? And I think the cost issue might not be as relevant as sometimes it is thought of. Thank you.
I think we have upload from you. Thank you. Thank you very much, panelists. And now we have reached the end of the panel session. And I'm told there are some few changes in the timetable.
So, yeah, that's everybody. Apologies for the delay, but we are hoping to be able to catch up with all the sessions. So I wish to announce for you the little changes in our timetable that we have. So from now onwards for the next 40 minutes, we'll be breaking out interactive parallel workshops. That will take a maximum of 40 minutes instead of 1 hour and 40 minutes. And thereafter, we also have an additional 40 minutes for the parallel session. And in that, we're expecting to cover the first 6 presentations in each session. And the remaining session will be moving tomorrow, sometime that will be also communication. Regarding the summer, we have late lunch early supper, and that will be recorded at around 16:30. So as we'll all be moving out and we'll meet our friend Asha, who will take us to our different place. Session 0.